Hello, everyone. Good evening over there in Spain, and good afternoon from Mexico. I thank Dr. Arthur Evangelista for having invited me to this Aorta Hub meeting. I will be presenting an interesting patient case. I have been very familiar with this patient for many years. He is the father of a female doctor residing in Tucson, Arizona. This patient originates from the state of Tabasco, southeast of the country. He lives by the sea. He is dedicated to the trade of seafood and fish to Mexico City, our largest market in La Viga, which is of fish and seafood. He has systemic hypertension and dyslipidemia since the year 2004, receiving pharmacological treatment and with good control goals. Hereditary diverticulosis in colon. The diagnosis was in 2001. Over 500 diverticula. It's pancolonic diverticulosis. In fact, he has a son who at 40 years old, they had to remove his right colon. Due to perforated diverticulitis, he didn't make it. In 2010, he underwent a sigmoidectomy and colostomy due to a diverticulitis perforated, and only after 6 months in 2011 was the end-to-end anastomosis done. Terminal. It was in 2020 that the diagnosis of atherosclerotic disease of the aorta was also made, not with that purpose. Atherosclerosis was present at the origin of the supraaortic vessels, in the coronaries, mainly in the right coronary artery, and in the left anterior descending artery. There's a dilation in this August 2020 study in the infrarenal aorta, up to 38 millimeters. A wall hematoma is seen, and at that moment a combination of vascular surgery was decided upon. Control of risk factors and optimal medical treatment. After this, a few months later, he was diagnosed with prostatic adenocarcinoma, stage clinical 4B, and he was placed on treatment involving dual hormonal castration and radical prostatectomy. The most recent diagnosis is muscle D with a fibroscan reading of 3F and a 2S. This is the initial study without contrast of Arturo's, where it can be seen that he presents with significant atherosclerosis in the aortic wall, of the aortic arch, of the ascending aorta. At the supraaortic vessel origins, aortic valve calcium was also seen, and calcified disease is also visible in the right coronary artery, and in the anterior descending we saw it before. The most significant aspect of this case is this condition that we are going to review in detail concerning the aorta infrarenal before the bifurcation. This is the non-contrast phase. Now we'll see the contrast-enhanced phase. Here I am going directly to the infrarenal aorta section, and we see how this is appreciated in the contrast phase, this hematoma. In the image, even some ulceration is visible towards the plaque. Before the bifurcation, good diameter at the bifurcation, and a plaque or part of that same lesion we observe superiorly that has spread towards the right femoral. I will zoom in on this image of the image view. This is how the renal artery origins are, and we move downwards to obtain this image view of the aorta with calcium, a wall hematoma. Perhaps plaque has spread to this femoral artery. The patient presents to the Institute's emergency room on August 7th, 2025, due to abdominal pain rated 10 out of 10. This abdominal pain had been present for 3 months with symptoms that were not worsening. He always denied fever. He did not present chills during these 3 months. But for the past 2 weeks, the pain has been intermittent, localized in the hypogastrium, and he refers it as transfixing towards the sacral region. The pain progressively intensified and lasted for increasing amounts of time. Not related to changes in bowel movements or intestinal habits, he came to the emergency room because the pain was accompanied with dyspnea on little effort and constant pain. He also reports urinary issues like tenesmus, frequency, and dysuria. The patient's chest X-ray, where the pulmonary fields are clear, there are no pleural effusions visible. The costophrenic angles are clear. The heart doesn't look big on this film, and we refer to this type of aorta as uncoiled. Its diameter appears to be increased in the area corresponding to the superior mediastinum. This is an electrocardiogram that is in the patient's file. It is from February of 2025, prior to the event. I am mentioning in the ER, where low voltage in the frontal plane is seen. He is an obese patient, I repeat. These artifacts are visible in the precordial leads B4 and B5, which are movement artifacts. He is in sinus rhythm with left atrial enlargement. When he arrived, blood pressure was 120/52 mmHg, a heart rate of 63 beats per minute, and a respiratory rate of 7 breaths per minute. Saturating 92% on room air, temperature 36.2 degrees Celsius. Frankly, the vital signs were quite good, with normal heart sounds. The only thing that stood out on exam was that hypogastrium palpation caused pain, and it radiated to the left iliac fossa as well as the ipsilateral renal fossa. Examine his laboratory results. There was actually no anemia or leukocytosis. The platelets were normal, and this is due to the fact that when the patient was in Tabasco. And since he had urinary symptoms, they saw a general practitioner there who prescribed him treatment with ciprofloxacin, and we believe that this kept the condition somewhat suppressed. In the liver function tests, everything looks fine. SCOT and SGPT normal. Gamma-glutamyl transpeptidase at 205. Alkaline phosphatase 138. The blood chemistry with a creatinine of 0.82. The CRP elevated at 3.66. The venous blood gas is quite normal with a lactate level of 0.6. Bicarbonate at 25. No other acid-base issues. Up to that point, everything looked quite normal. However, due to the severe abdominal pain the patient experienced, he underwent an abdominal tomography scan. Here we have the contrast tomography study that was done on the patient on August 6, 2025. And we will focus specifically on the important images. We appreciate this dilation accompanied by a hematoma. Of the infrarenal aorta we knew, but now it shows with the presence of increased fluid surrounding the wall, which appears heterogeneous. And we observe how this fluid appears at the level of the bifurcation. Nothing is visible here that wasn't seen before. There is the presence of this fluid. And up to there, we can see how the aorta is inflamed in the tissues that surround it. I am going to zoom in on the same image to see it in more detail. This is the lumen with the contrast agent. the hematoma we had previously observed, but this region of fluid and the region on the left side. Heterogeneous, we had not seen it in the previous studies after the bifurcation, nor had we seen these images, which surround the bifurcation. This made us notice. With such pain, so intense experienced by the patient, and initially it was suspected that this might be due to some acute complication of the aorta at that spot. And we have the comparison of the August 2020 study and the August 2025 one. Both studies contrasted. And here we can see the difference, how the connection appears here surrounding the aorta. Look how heterogeneous it looks. The image looks very different, especially the wall. It cannot be appreciated where it is clearly defined, and the presence towards the left side of this infiltration of the fatty tissue that is surrounding it, the aorta, at the bifurcation. I will do an even greater magnification, even more so that we can clearly define, well, these images. I'm going below the bifurcation. To the right, the 2025 study. To the left, the 2020 study. Look, the presence of that fluid surrounding the aorta, the wall is not well appreciated. The wall of the aorta where it terminates. It looks heterogeneous. This fluid, this collection, this image, and we are moving up towards the renal artery. And we reach the renal arteries. Other images, however, viewed from the coronal plane, similarly on the right, the computed tomography from the day of the intense abdominal pain, and the scan from 5 years ago on the left side. There you can see the plaque, you can see the ulcer, and you see, frankly, this collection surrounding the aortic wall that looks poorly defined aorta wall, and it was going more towards the left side, which is where the pain varied of the patient when evaluated. Based on these images and the suspicion of probable aortic rupture, we decided to explore of the abdominal cavity. So the patient was taken to the operating room. He was admitted as an emergency that same afternoon for exploration. It was found that the volume was indeed increased at the level of the aorta, the infrarenal abdominal. There we are taking samples directly from the wall of the aorta. There was purulent fluid present, and those samples were taken. They were sent to microbiology. That same day, the patient underwent an exploratory laparotomy, and many adhesions were found from the previous surgeries that had been done on the colon and then the anastomosis, we performed adhesiolysis. They went deeper and it was found that there was indeed an increase in volume. At the aorta level, there was fluid surrounding the aortic sac and there was free fluid within the abdominal cavity. Retroperitoneal lavage was performed, the aneurysmal sac was irrigated, and an aortoiliac bypass was made with a Dacron prosthesis, a pant leg of Dacron. The anastomosis was completed and another wash was performed. And we closed retroperitoneally with a bovine pericardium patch. In the following days, the cultures rapidly showed growth of a Streptococcus mitis belonging to the Streptoviridans spectrum and a Micrococcus luteus. Infectiology recommended 6 weeks of intravenous ceftriaxone while hospitalized, along with itraconazole for 2 weeks, and oral doxycycline for 3 months. After these antibiotics, to date, he is even on amoxicillin clavulanate, and this is chronic and indefinite. There is no date set to suspend it. This is the final surgical outcome. This is from December 7th. It is 4 months following the operation. This is how it looks now, with the bypass, aorta with the prosthesis, the collection surrounding the aorta, as the field is considered contaminated and the prosthesis is considered, despite the surgeon washing, became contaminated. For that reason, there is not a defined time limit for how long he will remain on antibiotics. For the moment, he is on amoxicillin clavulanate, and we have asked the patient to maintain adequate oral hygiene because these bugs that were found in the cultures taken from the pus that came out are very linked to mouth bacteria. The final diagnoses in this case are a mycotic aneurysm of the infrarenal abdominal aortic wall, secondary to infection by Streptococcus mitis from the Streptoviridans spectrum and Micrococcus luteus. Bacteria, first from the mouth, second related to acne. They even prescribe minoxidil to the patient so that the appearance of acne is not favored. He will continue on indefinite suppressive antibiotic therapy from infectious disease, currently amoxicillin clavulanate. My last evaluation was the first week of January 2026. He was afebrile and asymptomatic, with good lipid and glucose control. He lost about 8 kilos. He's not messing around. With good control of cardiovascular risks, negative procalcitonin and normal white blood cells. PCR also. Well, the PCR was slightly positive, but he is a patient who is still obese. With this, I want to conclude my participation in the Aorta Hub. I am at your service. Here is my email. I am in Mexico City. Thanks, Dr. Evangelista, for inviting me to the Aorta Hub, and I will keep contributing with cases from this national reference and national concentration center for now.